Good afternoon, everyone. It's so wonderful to see everyone here. This panel will shift our focus from COVID equity response to larger responses to health inequities, healthcare inequities, and how we can build these sorts of responses, institutionalize them, scale them up, partner together, and work on these responses. I'm really excited to be moderating this panel that has a number of old friends, and I'm going to introduce the panelists, who I guess will come up as I introduce them. First of all, Dr. Charles Anderson. Dr. Anderson, who clearly has a lot of fans, is a physician leader, healthcare executive, entrepreneur, speaker, and advocate for health equity. Dr. Anderson has served in a wide variety of roles over the past 25 years in the Boston healthcare community. He currently leads the Dimmick Center in Roxbury, Massachusetts as president and CEO. Dr. Anderson also serves on the Massachusetts Racial Inequities in Maternal Health Commission, the Opioid Recovery and Remediation Fund Advisory Council, and the Attorney General's Advisory Council on Racial Justice and Equity. Welcome, Dr. Anderson. Secondly, Dr. Joseph Betancourt. Dr. Betancourt is the president of the Commonwealth Fund, one of the nation's preeminent leaders in health care, equity, quality, and community health. Dr. Betancourt formerly served as the Senior Vice President for Equity and Community Health at Massachusetts General Hospital, overseeing the community's diversity, equity, inclusion, and community health portfolio, including its Center for Diversity and Inclusion, its Disparities Solutions Center, of which he was the founder, the Center for Community Health Improvement, and centers focusing on gun violence prevention, community health innovation, immigrant health, and global health. Next, I'd like to introduce Dr. Thea James. Dr. James Dr. James is another old friend and is Vice President of Mission, Associate Chief Medical Officer, and Co-Executive Director of the Health Equity Accelerator at Boston Medical Center. She is an Associate Professor of Emergency Medicine and Director of the Violence Intervention Advocacy Program at Boston Medical Center. She is a founding member of the Health Alliance for Violence Intervention, the HAVI, and in 2011, she was appointed to Attorney General Eric Holder's National Task Force on Children Exposed to Violence. Dr. Myechia Minter-Jordan, I'd like to introduce next. Dr. Minter-Jordan is the president and CEO of CareQuest Institute for Oral Health. She is a physician and business executive and leads a team committed to building a future where every person can reach their full potential through excellent health. Through her leadership, CareQuest Institute operates as a catalyst for systems change, bringing forward ideas and solutions to create a more accessible, equitable, and integrated health system. She is a founding member of the New Commonwealth Racial Equity and Social Justice Fund and has served on state and national commissions aimed at dismantling racism and achieving health equity. Finally, Dr. David Williams. Dr. Williams is the Norman Professor of Public Health and Chair of the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. He is also a professor of African and African American Studies at Harvard University. His prior faculty appointments were at Yale University and the University of Michigan. He is an internationally recognized author on social influences on health, and he is the author of more than 500 scientific papers, and his research has enhanced our understanding of the ways in which race, socioeconomic status, stress, racism, health behavior, and religious engagement affect health. So, welcome all of you. It's amazing to have this incredible panel. To kick off our conversation, I have a question for each of you that relates to your current work, but of course, many of you have been doing this work on health equity for decades in different capacities. So if you can reflect on your path that brought you to this point as you answer the question, but keep it to 5 minutes, that would be welcome. So first of all, Dr. James, what about your work at Boston Medical Center got you interested in collecting data around and responding to the social determinants of health? How did you begin conceptualizing the Health Equity Accelerator, and what outcome were you seeking, and what have you been seeing since its launch?
Okay, you said 5 minutes?
Yeah.
So I'll start off by saying, first of all, I'm honored to be here today with all my panelists and everyone in the audience. This is a special kind of a feeling in this room today. And I am an ER doctor by training, and if you're an ER doctor, if you're paying attention, you will notice patterns. In the winter, you notice when it snows, a lot of people will come in with what we used to call spaghetti hand because they stuck their hand in a snowblower, when the snow got stuck. But what you will notice, other things like the same people with the same things all the time. And you don't even have to be a doctor. If you're a clerk, if you're just in that space, you will notice these patterns. But if you're curious, you will wonder, why is that happening? You will want to understand, why is that so? But and the only way you can know that is to talk to patients, to ask them questions. Beyond the questions that you are taught to ask in a script when you're in medical school, which is only focusing on the disease, gives no context to what you're seeing. And, but what I came to notice and came to understand, and is clear to this day, is that people are consumed by something I call the dominant narrative. There's a dominant narrative that gives an explanation to those patterns that you see. And the bottom line of that messaging of the dominant narrative is that what you see is the status quo. It is the natural order of things. It is, it is something you can expect to happen. It's inevitable. And so people don't ask questions about it. And so that, to me, on some level, also sort of like drives like research, for example. We went from that to social determinants of health and disparities. And there are lots of researchers in this room, and I respect all of you. But a lot of disparity work was discovering disparities, but not necessarily an intentionality to close the gap. And it has to be designed with that. And the best way to get insights into that is by involving the people you're studying. And I know we've moved beyond COVID, for our panel, but when I think back to 2020, when COVID was happening, you would not need to study this to know which hospital in the city fared worse, or which community. You already know it. You already know that. And so one of the things that we did in terms of scaling up in leadership, Valerie, as you had talked to us about, we had a Vice President of Community Engagement and External Affairs, Trina Cherry, who's here someplace. And the one thing that Trina did that we had not done before was she reached out to leaders in the community, because we had a hesitancy problem and an access problem. And she convened these leaders multiple times to sort of solve those two problems. Number one, to find out why people, why there was hesitancy. And she convened Zooms for people to have their questions answered. And we stacked the deck with people like Dr. Sumu, one of our infectious diseases doctors, and others who are people of color who look like the people who were hesitant. And then the leaders worked with our strategy department and operations departments and walked through the community inside buildings to see what these places should look like, feel like, and we asked the community members where they should be. And so by doing that, we were able to, vaccinate people at that targeted population at really high rates, and the state was a partner by supplying vaccine. And so that kind of like led to a different way of thinking for us. Because the one thing that we did after that, and this speaks to how the Health Equity Accelerator came to be, first thing we did, we didn't come out with an equity statement. We actually looked internally at ourselves, and we were looking for disparities, but not across the entire enterprise, but not with the intentionality of just looking for them, but with the intentionality of interrogating the data back to root cause and attacking things there. And that staff has really grown up and expanded. And it started out with, and I'll just give this one example of, say, maternal child health, for example. Everybody in this room knows there's disparities about that. But we had an intentionality to close the gap on that. And so our OBGYN department saw that women were having postpartum hemorrhage, Black women, at twice the rate of white women in our hospital. We interrogated that data to see that it was associated with preeclampsia. And as you know, the treatment for that is C-section. We interrogated the data and saw that the sooner that decision was made to go to C-section, the less likely postpartum hemorrhage occurred. Then we interrogated the data more and saw that doctors were taking twice as long to make that decision in Black women. And so we did something immediately. Instead of continuing to study it, did something immediately, which was to standardize that decision-making process. Took the variability out of that, and the gap between decision to incision closed right up. And I'll also say that we have some early data now that shows that readmissions, postpartum has gone down a lot. So people like Elena Mendez-Escobar and Liza Fuentes and Sheila Facil, all those people, there's so many more. But we are doing all the different domains, looking at all disparities across the entire institution using that model. So it just, goes to show that if you have intentionality to do something, whatever you decide to do, and you don't say something like people love to say, you can't boil the ocean. I just think that's a way out for people, all the time to say that. If you don't say things like that and have intentionality, close the gap, that you can do it.
Thank you very much, Dr. James. I think that, that really exemplified a strategy that goes from just the data, which often is just research data, but in this case, you have clinical data, and you're turning that into a change for the patients on the ground as soon as you get the data and going further to the root causes. So that's very, very helpful. Thank you. Now, turning to Dr. Anderson, by design, community health centers have always moved beyond focusing on the delivery of health care and have done work to address the social determinants of health. With this in mind, how have the demands on community health centers changed over the past few years? And can you tell us a bit more about the specific model you're using at the Dimmock Center?
Sure. Well, let me do this because I think it's important, and I will try my best to stay within the 5 minutes, but that's a lot to answer. But let me say this because I think it's really important to understand that despite the bio that was read, at the end of the day, I'm someone who has a lived experience. And so let me explain what I'm going to say based on that lived experience. So, a son of an immigrant from Jamaica who came to the United States to disrupt healthcare in Buffalo, New York. Mom who grew up in the Deep South in Jackson, Mississippi, as a daughter of a sharecropper, escaping the Deep South to try to find a better way. And why end up in Buffalo, New York, many might ask, but that was one of the last stops on the Underground Railroad. So here I am as an 8-year-old, seeing my father enter medical school in State University, New York at Buffalo. And he was, quote unquote, raising hell. Why? Because there were very few to no Black medical students in the medical school. So I grew up as an 8-year-old, watching and being side by side with him, trying to change that at that medical school campus. My mom, with her experience and background, got very involved with the community in Buffalo, and everything from helping to start a charter school to trying to make sure that the elderly wouldn't get their heat turned off in the middle of the winter in places like Buffalo, New York, if you could imagine that was happening. And you can imagine which communities were mostly affected by that. I then watched my father build a family practice in Buffalo, New York. And looking at all the challenges that were faced at that point in time in the early 70s, he realized that a solution to getting to some of the things that were going to be important for the community we lived in and where we served was that you had to make it easy to access certain things and do it in a trusted environment. So what did he do? He put a lab in his practice in the early 70s. He then went on to put a pharmacy in his practice in the early 70s. He then went on to put imaging in his practice. Yes, he had his then 12-year-old son putting patients in rooms and learning how to take blood pressures and all the rest of that. So he was clearly doing some workforce development at the same time, which I think worked out okay. But the reality is I tell that story because I saw time and time again the experience of patients, community members, family members change right there in front of our eyes. We saw people go from an experience like my mom had, where she did not trust white doctors because of a lived experience where she was very clear growing up in Jackson, Mississippi at the time. You got to remember, in 1964, there were about 25 black doctors in the whole state of Mississippi. 25. Why? Most of them run out of town. And of course, the white doctors that were there didn't want to see black patients. An uncle who I never got to meet got his care when he was dealing with a significant tragedy by the only person that would care for him, who was a white veterinarian. So I say all this to say that I come to this work and what I bring to the Dimmock Center and building on the wonderful legacy that people like Dr. Myechia created there, was I bring that lived experience to, in many ways, coming back home. I grew up in a community health center. It wasn't called that at the time. It was Medical Group of Western New York, but the approach was similar. It was this clear understanding that delivering health and getting to good outcomes was about more than stethoscopes and antibiotics. It was about rolling up your sleeves, engaging community. It was about listening. It was about being really creative in addressing solutions and coming up with solutions to address problems right there in the moment. And that's what I grew up seeing. So now I land at a place like the Dimmock Center that has a legacy of that. This is an institution that's been around for 160 years, and it was started as a hospital by women for women. 160 years ago when women weren't allowed to practice medicine in the Harvard hospital system. In a community like Roxbury, which again is like home for me, primarily black and brown, primarily poor. Again, echoes with my upbringing and my lived experience. Where what we found ourselves doing, quite honestly, we put itself in this category of novel. I'm not sure how novel it is, because I'm just doing the stuff I grew up seeing. And part of that becomes in a situation like COVID, listening to community, listening to people's stories, listening to one of the gentlemen I remember speaking to early in my time there who lives in one of the housing complex at New Academy Estates, and him telling me, you know what, Doc, I don't go to doctors. Reminded me of my mom, reminded me of so many people I grew up with. He said, I don't trust doctors. I go in, they don't see me. They don't really want to take care of me the same way they might take care of somebody else. So why bother? He was very clear when doctors called him and said, you know what, we want you to come in and have this televisit. He's like, wait a minute, I don't come see you in person. Why would I come and do a visit over the television? And that's what he said, television, trust me. But then he went on to say that he's a cancer survivor. I'm like, well, how does that work? That doesn't really compute. Well, part of the story was his neighbor, trusted source. He was describing his symptoms to his neighbor, and his neighbor said, you know what, you need to get this checked out. He had no connection with the healthcare system. Remember, he doesn't go to doctors. He doesn't trust. Doesn't have that sense that he's going to be treated fairly. But that neighbor was able to encourage him, and that's who saved his life. He turned out to have colon cancer and was picked up early enough. So the things that we're doing at the Dimmock Center, quite honestly, is what was old becomes new again. We're listening to community. We're trying to design solutions in partnership with community. and trying to make sure that we don't go to the but instead and how we're going to do this. We approach every problem with a clear sense of there's a solution, and we engage people in that process. So that's what we're doing. I don't know how novel it is. Hopefully you understand that from my lived experience, it's not novel at all. I'm just doing what I was taught to do and raised in terms of how I think about healthcare. And fortunately, at a place like the Dimick Center and at a community health center, that's who we are by design.
So our next question is for Dr. Betancourt, but I'm going to start with a little bit of a preamble. At the height of the COVID pandemic at the Brigham and at MGH, we developed and utilized approaches that were new to our hospitals for enhancing health equity. We went into our communities, we partnered with our communities, we assessed and addressed the social determinants of health while testing for COVID and later administering COVID vaccines. These are obvious examples and lessons and new approaches the COVID response generated on which we can learn and build. Dr. Betancourt's amazing work in this regard has already been mentioned on the first panel earlier today before he got here. So Joe, you recently became president of one of the country's most important foundations whose focus is building a high-performing, equitable healthcare system. Can you speak to any new models for advancing health equity that you are exploring at the Commonwealth Fund and what you see as the critical issues for the future? And of course, how does it build on your amazing work leading this important COVID response at MGH?
Great. So thank you. I do want to take one of my 5 minutes for gratitude. So first of all, when you announced us, I was saying, this starting 5, coached by you, could beat the Celtics any night, right? We might be a little short. David maybe has us in the center power forward range, but it's a really impressive starting 5 with you, and I want to thank you for our friendship since the late 90s. Stand on the shoulders of this gentleman, certainly, who I served on the IOM report, Unequal Treatment with, who I learned so much about disparities. Served on the Board of Health with Myechia. If Charles and Thea and I did more Zooms during COVID together, we could just answer each other's words, you know. But I say this all to say, being with this family and being with you all after being on the screen for so long is inspiring. It gives life energy, and we're back at it again. So I'm thrilled to be here and honored. So a couple of quick things. I've been here for 20 some odd years and have learned so much and grown here as a healthcare professional with you all. I'd say second, I've had the great privilege and honor now to pivot to an organization, Commonwealth Fund, that leads with such integrity and that is so values-based and that carries a 100-year history, also founded by a woman, Anna Harkness, to really improve the common good and really ultimately aims to put its money where its mouth is, to be values-driven. The Commonwealth Fund is based in New York. We have a national and international portfolio, and it is a special place to me and to several people in this room who are Commonwealth Fund fellows. There was a Commonwealth Fund Fellowship in Minority Health Policy that was started in 1997, and there's several individuals here, Dr. Ojikutu, Dr. Simon, Dr. Sanchez, and probably more, who really came out of the Commonwealth Fund Fellowship, which is incredible to come full circle. Our foundation is really committed to high-quality, affordable, equitable care for everyone. And I'd say that we are aiming to do that. What I inherit is an organization that over its 100 years contributed to the first public health departments in the United States, first rural hospitals, first medical schools in urban areas, and really created a lot of the research for the Affordable Care Act. So I am blessed to enter into that space. We have portfolios now that focus on coverage and access. So the Medicaid conversation we were talking about, a lot of stuff happening in Medicaid. DACA now may be eligible for Medicaid. We have, 1115 waivers that are providing returning citizens the opportunity to get continuity of care out of the prison system. But we also have new requirements now for kind of new ideas around work requirements for Medicaid. So, we're working hard on that coverage and access piece, delivery system reform, cost control, and advancing health equity, which is our largest program. And so you might imagine that I'm going to do more in that space, given my history, and I will. And I think the key ingredients that I hope to bring to this is genuine, authentic leadership that learns from people on the ground, and decisions aren't made in the ivory tower. an approach to diversifying our grantees, to really funding those who've been there and done that, not who are showing up because it's fashionable and because there's dollars in the mix. I would say that we do need to be strategic and continue to connect equity to quality, safety, value, and cost. And then finally, I think a concept that we were building on, which is we want equity from doorstep to bedside and back across the entire continuum. So those are the areas, Valerie, in which I think our foundation will now enter this next part under our leadership. And I'm going to depend on, I think, so many people here and so many of our lessons learned, because we are privileged to be here in Massachusetts. I mean, we don't have it right, and we always want it better. But if you look across the nation, clearly there's a lot wonderful about what we've done and what we can do, and I hope to really shine a light on that with leaders like you in the audience and certainly my colleagues and peers here. Thank you.
Thanks so much, Joe. So next, Dr. Myechia Minter-Jordan. You recently also shifted into a key philanthropic leadership role. How can philanthropy lead and/or push systems and catalyze institutional change to advance health equity? And what motivated you to focus on oral health disparities, and how can oral health be better integrated into overall health to achieve racial health justice?
Thank you for the question, and also let me just share in the gratitude that I have for being on this stage with all of my friends and colleagues, and for being in this room, and for being off of Zoom, for sure. So one of the things I realized in my prior role at DMIC, and I know this probably speaks to your heart and many others on this stage, is the hierarchy within philanthropy. And this is within any entity that gives money to another organization that they think is of lesser value, right? And so how many of us have experienced asking for a grant, being told you have to jump through 30,000 hoops and contort yourself in a way that doesn't really reflect the programmatic intent that you had when you applied for the grant? Like, let me see a show of hands, right? So moving into philanthropy, I recognize that there is so much power to be had in creating a partnership, right? And one of the things that I've discovered as part of being one of the founders of the New Commonwealth Fund is that 2 cents on every philanthropic dollar in Massachusetts goes to a Black or brown-led organization. 2 cents. And so being on this side, being able to lead an organization that is the largest philanthropic funder in the country in oral health allows me to think about it in a different way. Being part of the New Commonwealth Fund and raising dollars to give back into communities, primarily to organizations led by Black and brown leaders, allows me and my colleagues to do things in a different way and to shape philanthropy in this state, in this Commonwealth, and hopefully in this country. We need to do better. And philanthropy, if it was working the way that it was constructed previously, COVID wouldn't have happened in the way that it did, right? How many dollars have been expended in Black and brown communities by philanthropic organizations that have actually not moved the needle on systemic racism? And so clearly something needs to change. And so that is the reason why I'm so excited to be the leader of CareQuest Institute for Oral Health, because I can do things differently with my team, with my colleagues, and through the New Commonwealth Fund, we can also influence the way philanthropy happens nationally. Why oral health? I'll get that question all the time. You're an internist, why did you go into oral health? In my role at DMIC, I did so much work with colleagues like Thea and others in behavioral health integration. Behavioral health is part of our body, is part of our minds. We are one body. Oral health is connected to so many things. It's connected to maternal morbidity and mortality. It's connected to diabetes. It's connected to cardiovascular disease. Why is our system so siloed? And that siloing impacts Black and brown communities disproportionately. 68% of Black people have had a poor oral health experience as compared to their white counterparts. 52% of Latinos. 3 times the Alaskan Natives and American Indians go to the ER 3 times more than their white counterparts for oral health disease. And these things are preventable. When I was at the DMIC Center, I recognized in our Head Start and Early Head Start program that we were putting babies to sleep because they had cavities. How do you fix a cavity in a 3 or 4-year-old? You have to give them anesthesia in many cases in order to fix that cavity. 100% preventable. Thank you, Thea. So these are the things that got me excited about moving into this space around oral health. They continue to excite me in the role that I can play, both in philanthropy and in oral health, and bringing oral health into these discussions, because I know that our communities are disproportionately impacted in terms of these conditions and these diseases, and a lot of it is preventable. So I'm excited to be part of this discussion. I'm excited to be able to use my platform to be able to bring these things to the forefront, but philanthropy can do a lot better. And I'm excited to be part of the conversation to push our organizations to think differently, to broaden the table, to bring community into these discussions, and to think of these as partnerships. It should not be a hierarchy. It should be a partnership, because those who are on the front lines know this work the best. They know the people that they work with. They understand the issues more than anyone who sits in the ivory tower. And we have to do things differently in order to finally move the needle on systemic racism in our country. Thank you.
Turning to Dr. Williams, based on your decades of research, can you speak to the role of structural racism and other social and structural determinants in shaping health equity? And are there any additional examples or models that you would like to highlight on how healthcare leaders, philanthropists, and policymakers can address these social and structural determinants in their work?
Thank you so much for the question. It's truly an honor for me to be here and be on this panel of people who I admire for the difference they are making in the trenches every single day. I sit in the ivory tower, and I do try to raise my voice whenever I can to make a difference, but the work that you do is priceless. There's a lot to answer in 5 minutes, but let me try. The big point we need to begin with is we need to recognize that what we are doing is not working. And we have to make a commitment to do things differently. I'll give you 2 statistics that illustrate that point. In 1978, as a result of the civil rights policies of the 60s and 70s, of the war on poverty of the 60s and 70s, the gap in income between blacks and whites had narrowed. And it was now African Americans earn 59 cents for every dollar whites earn. That's 1978, the peak year of the narrowing of the gap. In 2018, African Americans earned 59 cents for every dollar whites earn. Now, it hasn't been stuck at 59 cents. Reaganomics was not good to the African American community. It fell throughout the decade of the 80s. It was not until the mid-1990s it got back up to 59 cents. But we haven't made progress. Most Americans think we've made a whole lot more progress than that. One more statistic. In 1950, the average white person lived 8 years longer than the average black person, life expectancy at birth. In 2020, the average white person lives 6 years longer. 6 years longer. 2 years difference from 1950. If you look at the life expectancy of whites in 1950, it was not until 1990, 40 years later, that African Americans had a life expectancy that whites had in 1950. What we are doing isn't working. We are not really moving the needle on eliminating inequities in health. We have to challenge the upstream structures of racism that is replicating this inequity on a large scale. And until we do that, it's not going to work. I've talked about segregation and the impact that residential segregation have. There's nothing negative about living next to someone of your own race. The problem of segregation is not segregation per se, but the clustering of social ills and the absence of opportunity at the neighborhood level that exists in segregated communities. One of my colleagues at Harvard, a very distinguished economist, using national data on blacks and whites, and this study is 25 years old, he showed that statistically, if you eliminated segregation, you would completely wipe out black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. All of these striking differences are linked to opportunity at a neighborhood level. And until we get to the point where we recognize what the problem is and are committed and have the political will and have the necessary empathy to say this is unacceptable in this society, we are not going to make the progress that we want to make. I want to point to one example that is quite striking to me of what has happened as a result of the pandemic, as a result of George Floyd's death, that the Rush University Medical Center in Chicago has embarked on an ambitious initiative. They have documented that within their service area, there's as much as a 12-year gap in life expectancy between people who live in one census tract compared to people who live in another. And they have made a commitment that they want to cut the life expectancy gap in half within 10 years. And what have they done? They have invested millions of dollars into an initiative where they are trying to leverage the economic clout of their organization to improve the health of the disadvantaged neighborhoods that they serve. So they've made a commitment that they will now hire more locally, developing apprenticeship programs starting with the high schools, of getting people in disadvantaged community that they serve to get entry-level jobs within the healthcare sector and to have pathways of process where they can move forward. They have decided that they will also purchase, whenever possible, all of their supplies locally, supporting local businesses to do that, especially in their disadvantaged neighborhoods. They have decided that they will contract locally whenever possible, again, giving preference to persons in their neighborhood areas that they serve in order to do that. They are even providing incentives, financial incentives, to their employees to volunteer for local community organizations. Quite an impressive effort that is heavily focused on raising the standard of living within those neighborhoods that they serve. Because when people have something to live for, they can better invest in taking care of their health and maximizing the opportunities that they have. So that's one example of a fairly dramatic effort of a major healthcare system. I don't remember the amount, but it's more than $100 million they've invested as they kicked off this initiative. It's quite striking. The New England Journal of Medicine Catalyst has a description of this if others want to look for it, but it's a dramatic example of what could be done. And it will take that kind of dramatic shift and that kind of commitment to make a difference in lifting the lives of disadvantaged communities in this country.
What an amazing example, and I hope there were hospital system leaders sitting here who can think about how we could apply such a model here in Boston. So our next question I would like each of you to answer is, looking back at your career, how have you disrupted racist and oppressive structures at the institutional level? What were some of the challenges you faced, and where did you find support to overcome them? And I think because we're trying to focus on the way forward and what we've learned through COVID, focusing on something recent would be great, as opposed to your whole career. And I'm gonna start as an example. So some people know, but I lead a program at the Department of Medicine in the Brigham called the Health Equity Innovation Pilot Grants. And my co-leader here is in the second row, Dr. Candace Feldman. And this program gives grants of $40,000 to individuals in our department, has to include a resident or fellow or medical student with a faculty member, to investigate a health inequity that they have observed in the care of patients in our department or in our community. These have included things like the inequitable security response that was identified at the Brigham, the lower likelihood that Black and Latino patients with heart failure would be admitted to the heart failure service, and other issues such as the inequitable control of diabetes among Latinx patients and Black patients. We have invested more than $1 million in this program, but it has unearthed numerous inequities, has gotten trainees who are young and energetic and passionate involved in reversing these inequities. And we believe many times we're putting ourselves at a little bit of risk in bringing these problems forward, exposing them, and showing the hospital that it could do better. So that's my example. So let's start here and go around.
Sure. So I mentioned the New Commonwealth Fund earlier. There were 19 of us when George Floyd was murdered who are in positions of, I guess, relative power in the state, black and brown leaders. I got a call saying we need to do something. It's not enough for us to do things individually, we need to do something collectively. So we created the new Commonwealth Fund for Racial Justice and Social Equity, and we decided we were going to raise $100 million. We raised $30 million in 2 years, and we said we're going to give it to black and brown-led organizations throughout the Commonwealth, not just in Boston, throughout the Commonwealth. We said we were going to focus in on 4 at the time, 4 pillar areas, now expanded to 5. Arts and culture is the newest, health equity, criminal reform, youth empowerment, economic empowerment. And we said that we're going to let the communities tell us how to do this work. And so one of the best calls I ever had was to get on a Zoom call with 30 leaders of community organizations, some of whom who had never heard of us, to tell them that we were giving them each $50,000 because we believed in what they were doing and they were going to teach us in these spaces about how to do this work. And so we continue to do that work, we continue to raise funds, we continue to give it back into the community, and that's one of the ways in which we're really trying to anchor in on, as I mentioned earlier, changing the way philanthropy is done, but also lifting up organizations who have not been privy to philanthropic dollars within our Commonwealth. It's a very narrow network of philanthropic organizations. They go to the usual folks, most of whom don't look like the people on this stage, and they give them the dollars. And when you think about startups and the startup economy and how much money is in VC funds for an idea, checks are written for millions of dollars, but they won't extend the same grace or extend the same respect to organizations that are led by black and brown leaders, and we aim to change that. The other example I'll quickly give, and I'll pass it to my colleague, is within our own philanthropic giving within CareQuest Institute. When I joined, we said, we're working on equity, we're giving out dollars to community-based organizations nationally. But when I asked about what our own data was, about who are the boards, who are the leaders, how many community members are impacted by the dollars, we knew the community members, but we had no idea who the leadership was. So we're now doing an internal look at what does our philanthropic giving look like? How do we ensure that we're seeking out those organizations and equitably distributing dollars? And I think that's part of the work that philanthropy has to do, is do that internal look and make sure that as we say that we're focused on equity, that we're doing that within our own walls and that we're collecting the data to ensure that that's actually happening.
I would say, to add on to what I was talking about earlier, and I was talking about the sort of commitment that BMC made. It was like it was a commitment to an organizational transformation. It wasn't just a project, but we said that we would transform, and everything that we would do would be through the equity lens and with an intentionality towards closing gaps and health justice. And so we have pillars lined up for that also include the root causes of economic injustice, for example, because it seems that in and of itself is the root cause of everything, because people can't prioritize health when they're prioritizing survival. So again, I hate to keep calling people's names out and stuff, but like Trina is leading some workforce development work, for example, with various different partners in Boston. Elena and Sheila and Liza are also focusing on the research around these various different pillars. So everything that we are doing is sort of focused on eliminating the gaps that people have, not just closing the gaps, not just giving people subsidies, which really don't alter life course trajectory, and they just are repeated sort of gap-filling things that prevent people from falling. So that internal thing that Dr. Williams also, what Rush is doing, we're also doing a bit of that through HR. We are bringing people in for jobs. We recently had a goal of 52 people in a year, and we've done like 700 people, so we're working on that as well. And internally, through human resources, we have programs, once again, that take people from entry-level jobs up to managerial jobs, and we have some work in director-level jobs as well. And externally, and maybe Charles, you'll speak about that as well, we have the Health Equity Compact, you know, in Boston, where we have like 70 members, you know, who are focusing on this. And the other thing I would like to highlight is the Council of Boston Teaching Hospitals, who also do a community health needs assessment together, and all of us are sort of working on community health improvement plan, and also economic mobility, behavioral health, access to services such as childcare and things like that. So we are doing an internal intentionality towards the domains that we have, with intentionality to close gaps and alter life course trajectory through enabling people to change their socioeconomic lanes. And we think through addressing things from that point, the other things will sort of fall in line.
It's interesting. As I think about, you asked about what are the things that I might have personally done. And I'd say for me, what's most interesting is that I decided to be more intentional about how I utilize my time and my talent and blessings, as I like to think about it, and opportunities that I've had. A little bit on the treasure side, but not enough treasure to spread around. But the reality is I decided to be much more intentional. And so when, during the pandemic, lost a really close friend, one of the first 1,000 people to die during this pandemic, and spent a lot of time thinking about how to be more intentional there. And I learned a little bit more about what I had already known about these wonderful community health centers and the design of community health centers that really are about being centered around principles that by definition involve community. 51% of the board, my boss, is the community. Looking at institutions that really from the very inception in the mid-60s were focused on this war on poverty and a real focus on these social determinants before we were even calling them social determinants. Organizations that had really in mind the importance of economic development. A place like the Dimick Center, aside from caring for the 19,000 people that we care for on an annual basis, and over 300,000 visits that we have through all the portals and doors, also is the largest employer in Roxbury. And what could be done there as we really focused on not only being the largest, but being the best? What would that look like? So really for me, it was being really intentional and saying, this is a place that I need to lend my time, talent, and my treasure. And then getting there and very, very quickly figuring out what are some of the gaps that we can immediately fill together, understanding this amazing platform that it is. And one of those is that I realized, and we all realized together, that during this pandemic, the death rate for black men due to overdoses, and this opioid pandemic, went up by 69%. I found myself on this amazing campus, 9 acres and beautiful buildings, and last thing one would want to do in one's first 90 days is talk about having a capital campaign. But that's what we needed to do, because we had to add more capacity, and we had to build what is going to be the first clinical stabilization service or step down from detox for men in the city of Boston. So really answering this call about how I'm going to be intentional about using my time, my talents, and my treasures, and really engaging this wonderful team of people both inside our walls and outside of our walls to really heed the call, answer the call. We did mention the Health Equity Compact, and I think that's really an important part of this, of how we use our time, our talent, and our treasure. And when I got this call to be part of a group of what's now 70 black and brown healthcare professionals, and quite honestly, having been in Boston for 30 years, I never thought I'd be able to sit at a table where I can say I've got this many black and brown men and women who actually are leading critical organizations in the healthcare ecosystem of Boston. I never thought I'd see that happen. So to be part of that and to start to look at how we can advance health policy to make a difference, how we can focus on these issues of workforce, which is a critical part of changing the experience that everyone has, to make sure that you have the opportunity to be sitting with someone that you know has your best interest in mind and that you can connect with, because of the fact that you have a shared life experience makes a huge difference. We've seen study after study that allows us to know that when you have concordance in race and ethnicity for that between the provider and the patient, that the satisfaction in that visit is much different. And it's easy to extrapolate how that satisfaction can lead to a difference in compliance, a difference in listening, a difference in sharing. So again, for me, it's coming to this amazing platform, which is the Demick Center, which does so much great work, and to be able to be a part of the great work that's done by over 500 people and supporting them in doing that work, because as I tell them every day, I work for them. My job is to support, because they're the ones doing the hard work on the front lines. So that'll be what I'd share there. Thank you.
Thank you so much, Dr. Anderson. I think it's a great message for all of us, thinking about how we can go forward each day with being as intentional as we can be with our own time, our own careers, our own energy in advancing health equity, and also the important way in which the Health Equity Compact fits into this work. Joe?
Yeah, so just 3 quick things and then 3 lessons for them, which I think are probably even more important. And I would just double down on this. None of this is I. This is all we and a lot of we's. So I think, first, in 2007, the Disparity Solutions Center created something called the Disparities Leadership Program. And the idea here is that we would create a movement among hospitals, health plans, health centers around the country to better identify and address disparities. To me, that was something I've been very proud of. We worked with over 400 healthcare systems in now 37 states and 3 countries internationally. So that the fact that everybody was encouraged to take a step forward in this space was exciting. But I think the big lesson there was that really change was happening at different paces in different places. And you needed to be strategic in a South Carolina versus Massachusetts versus a Wisconsin. And I'd say that I learned a lot about strategy, organizational change management, and kind of how to move the ball forward in ways that will serve me very well now in the national role I have. I'd say second, and this is more of a clinical one, I'm still a primary care doctor, and during the pandemic, we did a lot literally from doorstep, bedside, and back. But one of the things I was proudest to be involved with was at Mass General, when 30% of our patients in April of 2020 were Spanish-speaking, and interpreters, because of PPE and other factors, just weren't available, that we were able to mobilize over 50 Latino and Latina doctors, many who volunteered their time, from 15 different countries, 15 different disciplines, to make sure that every day, 7 doctors during the day, 4 at night, for 8 weeks during the entire surge, there was always a Spanish-speaking doctor going into any room of any hospitalized COVID patient. And I think the big lesson for me there was that we are incredibly resilient, and our communities and our patients are incredibly resilient. We saw it every day. We talk a lot about disparities and kind of, fall into deficit model, but we need to lead more with the strengths of who we are and who our communities are. I guess the last one is, I spent a lot of time at MGH trying to move this ball forward also strategically, through quality, through safety, any angle, any kind of way I could get my way in. And the murder of George Floyd gave us an opportunity to really launch the Structural Equity 10-point plan, which was, I think for me, the biggest lesson, finally the pivot to move from heavy on aspiration to real on execution. Goals, timelines, milestones, accountability. For all my career, I think, there was a lot of talk, there was a drip, drip, drip progress, but this created an opportunity for us to really get real, like we are in so many other places of healthcare, around equity, and I think only time will tell if we've succeeded in that regard, but that's, I think, been a very, very important lesson as we go forward is, how are you going to be, as Rush is, deliberate, strategic? How are you going to hold yourselves accountable? And how we can move equity from kind of a standalone, from kind of bolted on to really built in. And that's what I'm, I think, driving towards, and I think those are the things that I'm very proud of.
Let me be quick. I know time is ticking. I would say it's an old Negro spiritual that said, don't let nobody turn you around. And I had to learn that early in my career, trying to do work on racism. I remember one of my early papers, I got a review back, and the reviewer said, the term racism does not belong in a scientific paper. Racism is an ideological concept that cannot be measured. And that's where the thinking was in the early 1990s. I remember speaking at the National Center for Health Statistics conference, probably in 1992 or 1993, and you know, there's this final panel of this, a conference on minority health. There was an African, I was a black person, there was a Latino, there was an Asian American, there was a Native American, and we were all to talk about what are the priorities. And I said, a priority for future research is for us to develop and measures and document the role of racism in adversely affecting health of people of color. And I remember a white gentleman raised his hand and he said, what Dr. Williams said to do is important, but what he's asking us to do is impossible. We will never be able to measure racism. And I remember saying to him, if you ask me today, do we have valid and reliable measures of racism? I'd say no. But I said, we measure self-esteem. If we measure self-esteem, why can't we measure racism? And I just picked self-esteem out of the blue. And I went back, and this is the other key. Utilize the wisdom that exists around you. I went back to, I was at a faculty University of Michigan at the time. I went back to University of Michigan. That comment that we could never do it was just the added motivation I needed that we were going to do it. And a senior researcher at the time, the premier African-American researcher was the Professor James Jackson, who founded a program of research on black Americans in the 1970s at Michigan. And I went to him and shared with him the idea of developing measures to capture racial discrimination. And he said, let's do it. And he got behind me, he helped to raise funds so that we could get a large sample to do this work, and we were able to publish the first paper together in the mid-1990s. I also recall that the notion that if we wanted to do this work, we needed to build the literature, we needed to create the evidence. And I approached Richard Cooper. He was a white cardiologist, but very committed to issues of racial equity. And he was the editor of the journal Ethnicity and Health that came out of the Association of Black Cardiologists. And I said, Richard, I have this idea. Would you allow me to be the guest editor for a special issue on racism and health? And he said, yes, David, let's do it. And we did a special double issue with 16 papers on the topic, laying the foundation for the research in that area. And so what I would say to other young people, don't let nobody turn you around. You have an idea, go forward, but seek the wisdom of others who can help you.
We love that, and I know we all needed to hear that. Thank you for that inspiration. So I think we have time for one or two questions from the audience before we wrap up our panel. Are there any questions? Yes, Paneet. Can someone give him a mic?
First of all, thank you for such a great panelist here. I truly enjoyed all your answers. A question I have is, when I was hearing and listening to you, Dr. Williams said about black folks were making only 59 cents to dollar compared to a white person. And then I know the other speaker said there were only 25 doctors in Mississippi at the time. So why is the case, if you compare, there are 42% based on the report I was looking while you guys were talking about from Kaiser Family Foundation, that there are 42% people of color in the United States as of 2022. And if you compare that, in the people of color, you have you have Hispanics, you have Asians, you have black people, or African American. African American are lower in number compared to, being doctors, being engineers, being CEOs, and so on. I was looking at the labor statistics. They are only 7%, 3% or 4% compared to white people, 77%, 80%, so on. Why is the case that black people are not kind of left behind compared to white and other races? What would it take to bring those ethnicity group up the chain so they can have more doctors, more engineers, more CEOs in the nation where you have 42% of people of color? What should be done? I've been hearing more about what are the problems, But I'm looking at what are the solutions out there where you guys are at such a good positions. What it will take to bring these people up. Are there have to be reforms made in education? Are there have to be reforms made to people get out of the poverty so that the folks, the African American folks, can be bring up to at least 30, 40, 50% close to what people of color, the white folks are? Thank you.
I would jump into that quickly. We need to create opportunities at a neighborhood level that are accessible to individuals so that they can take advantage of them and do them. If you look at the work of Dolores Acevedo Garcia at Brandeis, she shows on 29 different indicators of access to opportunity in the United States, and this Child Opportunity Index, and she looks at the 100 largest metropolitan areas in the US. Who lives in the very low and low opportunity neighborhoods? 67% of all African American kids, 57% of all Latino kids, over 50% of all Native American kids live in low opportunity areas. If you don't have access to opportunity, you are blocked from those opportunities. The other point I would mention, discrimination still exists. Diva Pager is a sociologist. She took people with identical resumes, black and white people. The only difference is the race of the person submitting the resume. And what she documented, that with identical resume, and she had one of the pairs of the black males indicate he had served a prison sentence for cocaine possession, one of the whites, a white male with a criminal record is more likely to get a call back for a job than a black male whose record was clean. Okay? So discrimination still exists. So we have to work on eliminating that discrimination, and we also have to work on creating opportunities at the neighborhood level.
You know, I would just add, you know, you asked the why, and I know you asked for solutions, all of which are the things that you raised, Doctor. It's two words. It's systemic racism, right? Like this country was built with intention to hold people of color down and back. So when we are talking about solutions, you have to go to those root causes in order to create change. And if we continue to say, like, you know, why don't they just lift themselves up by the bootstraps? They don't have the bootstraps, right? There were laws put in place to prevent people from buying the boots, right? You can only get boots with no straps. So, I mean, this is how this country was built. And so the dismantling is what we are all responsible for doing, is what I would say.
What I would add to that very quickly, just to give an example of exactly what we see. We're doing a project right now with a group of young people at one of the housing complexes right near the Demick Center. And it's training them about how to take blood pressures and engage with the community and talk about issues of cardiovascular health. And one of these young ladies, who's a student at Northeastern, had to drop out of Northeastern. The reason why she had to drop out, because unfortunately her aunt passed away from a drug overdose, and she's now caring for an 8-year-old and a 10-year-old. That's the reality that she's facing. So when we start thinking about dismantling, we think about that aunt and what put that aunt in that position. That aunt had dealt with homelessness. That aunt had dealt with lack of opportunities. Now coming through a pandemic and dealing with all the isolation without the same sort of social infrastructure that then puts her in that situation, that now puts this young lady in that situation, who will be one of those who you'd also wonder, how is it that she's not able to be a doctor or nurse or business person, etc. That's the root cause. And we have to be prepared to embrace that and understand that there are solutions. There are solutions. But we're going to have the political will to be able to address those solutions. And that's where we have to start.
Yeah, I think as you said before, we have to be intentional in our efforts to both dismantle some of these structures, but in addition, address new solutions. Because we can't dismantle structural racism, but on a person-by-person level, we can make a difference, and we need to be intentional about that. Dr. Acevedo.
This is more, so I'm Sabrina Sumo. I'm an infectious disease physician at Boston University, Boston Medical Center. This is more a comment than a question. First of all, thank you, Dr. Ojikutu and Dr. Hall, for bringing us together here. I felt compelled to say something because it's so nice to be in a room with like-minded people. I was in the trenches with many of you who I've only met on Zoom, and it was just so good. I just thank you for creating this. My challenge to you is I'm so glad that we're not just talking about describing, but we're talking about solutions. I'm hearing about a lot of solutions. Can we come back here next year and talk about those solutions? I know what we're doing at Boston University. I know what we're doing at BMC, but I'm hearing about all these wonderful solutions. I want to talk about the solutions and how we're changing things here in Boston. Thank you very much.
Thank you.
So I know we need to wrap up, and originally I was supposed to ask you all each for 2-minute comments about your key message, but if you could give us 30 seconds, maybe a little longer, on your key takeaway message regarding how we can go forward in dismantling structural racism and solutions that foster health equity broadly, not just for COVID.
You want me to start?
Yeah.
I'll quickly start. I love the question about solutions. I hope through all of the comments, you heard that there are lots of solutions at play, right? So we've talked about the Health Equity Compact, and I would encourage you to look up the Health Equity Compact and look at all of the various platforms that are being advanced through that work. And part of it is around data collection, part of it is around pushing policy and creating ways in which we can ensure that people have equitable access to health care. The new Commonwealth Fund, giving dollars back into the communities led by Black and brown leaders, those are all solutions. And so I think maybe they got clouded in part of some of the commentary, but I think the takeaway is for all of us to go back to our various organizations and positions and understand what can we individually do and how can we sign on to other groups that are doing the work and pushing forward solutions. There are a lot of solutions that I know are in this room, and I look forward to having more of an opportunity to discuss them as well, but know that there are some that came out of even our discussion today that we really do want you to become engaged in as leaders in this space.
I would say intentionality, and intentionality to do something different that will change what you already see. For solutions, ask the people who you are actually studying or trying to help. They should be at the table no matter what it is. They should inform the solution. They should be co-creators of whatever it is you come up with. And we need to, I would say, focus on economic mobility. And by that would mean that not to think about subsidies and filling gaps, but eliminating gaps. Subsidies would be okay if they were designed for people to someday not need them, but they're not. They're traps, generally. And the last thing is just partnerships, external partnerships. Healthcare, you can't do it alone, all across different sectors.
I would echo this intentionality around time, talent, and treasure, both as individuals, how we influence our organizations to think accordingly, and our partners. There are wonderful partners out there who are also trying to answer this question about how they can be more intentional in those 3 dimensions. So let's always start to think about how to build on that. And the second thing I'd offer is really taking full advantage of the fact that we're in a state with infrastructure that can support a lot of what we're talking about. There are 50+ community health centers in the state of Massachusetts caring for 1 in 7 people who live in the state. There are 22 in the city of Boston caring for every other person who lives in the city of Boston. We've got infrastructure. Let's figure out how to partner time, talent, and treasure with that infrastructure and know that we can better understand the problems by engaging those who really are living those problems, and that together we can drive solutions.
Great. I think many of us have been at this for a long time. I'm going to take a little bit of a twist here. Commonwealth Fund produces a report called Mirror Mirror, where we look at U.S. compared to other OECD nations year after year after year. We spend the most, have the worst outcomes, have the biggest disparities. While we are distracted talking to ourselves, and while we are talking about nibbling around the edges, The real decisions are around financing and regulation. When they say devil in the details, the devil in the details of structural racism are really in financing and regulation. And ultimately, the corporatization of healthcare that we are seeing now going unchecked in many, many ways. And you could read Don Berwick's article, you could read the article out of Millbank last night, and the subsidizing of taxpayer dollars for for-profit and quote-unquote not-for-profit will leave our communities behind while we keep talking about coaches, navigators, little things here, little things there. So we need to up our game in that space, and that's the space that we're going to dig in deep, and I look forward to your partnership.
In 1899, W.E.B. Du Bois wrote a book called The Philadelphia Negro. He has a chapter on Negro health showing the disparities in health. As he came near the end of the chapter, he said, "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race." And he continued, "There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." So here, the single biggest problem is, as is society, we don't care. We don't care what happens to black and brown people. What he called the peculiar indifference, scholars today call the empathy gap. And it's been documented on every continent. We feel the pain of what happens to someone of our race more than someone of a different race. So the challenge we face is, how can we tell the story of the challenges of the disadvantaged populations we care about in a way that emotionally connects? So we need to work with communication scholars. We need to learn how to frame the issues so that people can feel the pain that our communities experience and rise up and say, this is unacceptable, we will not have this in our country, we will do different, we will then have the political will to make a difference.
I'd like to thank our amazing panelists for a wonderful, inspiring, and powerful discussion. And I'd now like to take the opportunity to transition to our next panel.